Aloha, welcome back to General Pharmacology. Well, let's move the PowerPoint slides and get started. Today we're going to cover 2.5, the second part of 2.5, blood thinners. I think the last time I tried to squeeze this in with the first part of 2.5. I think the people in the room were half asleep when we got to this point. Some semesters I divided into two parts, and then some reason I get in a big hurry and squeeze them together. And so we're going to go back and do this again. If you're watching reruns, this will be in the proper order. But for this semester, we're going to go a little bit out of order and go back and talk about the blood thinners and actually get to thrombolytics this time. All right, all this time, we have been trying to combat with atherosclerosis. And atherosclerosis is this plaquey buildup inside of an artery. And what do we try to do? We try to control our blood pressure. That's very important to avoid all the things that we're going to talk about today. And then we try to control our cholesterol by lowering our LDL, our low-density lipoproteins, and raising our HDLs, or high-density lipoproteins. Another way that we're going to control atherosclerosis is to quit smoking, and then eventually, when we finally get to endocrinology, we're going to need to control diabetes mellitus as well to control atherosclerosis. And so there's all sorts of lifestyle changes that we can do to avoid this. Sometimes we have to resort to medications, and this is a pharmacology class. All right, well, everything you read when they talk about atherosclerosis, they talk about narrowing the artery, and when the artery is narrow, so this would be the part where this is a slice through the artery, and we have plenty of atherosclerosis right there. And this is the narrow part of the artery, right here, where diminished blood flow, and everything you read about atherosclerosis will tell you the problem is diminished blood flow, and that's half the story. But the other half of the story is this atherosclerotic plaque has an endothelial lining on it. And there's this little white line is the lining of the inside of the artery, and it is very, 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 very important to blood clotting and the health of the artery. And notice this endothelial lining right here is laying nicely against the arterial wall the way it's supposed to. And so it's a little bit better health than this endothelial lining right here that's sitting against the atherosclerotic plaque. It's not healthy, and something it'll do is break away. It'll ulcerate. And so atherosclerosis, one of the big problems we have with atherosclerosis is ulceration of the endothelial lining. I think the first time I said that, there was this confused look in the front row. And so now that's like, oh, we've heard it twice. How nice. All right. Well, when this endothelial lining is exposed, it can cause blood clot formation, and that blood clot can move down and become an embolism and block artery downstream. And this is, of course, especially tragic when this happens to the brain or to the heart. Right? This can happen in the eyes as well. This can happen anywhere. All right, before we start beating up on blood clots, keep in mind the formation of a blood clot, or a thrombus, as it's more commonly known, is a normal part of the body's self-healing homeostatic processes. We need our blood clotting system to be working all the time because we're constantly leaking from the little teeny tiny capillaries and all sorts of delicate microscopic blood vessels. And so the hemostatic system, blood static, the stop bleeding system, is constantly plugging these leaks with blood clot, with thrombus, and then your body's constantly breaking down the thrombus once the leak has healed. And so this is going on all the time. And if you ever see somebody without a functioning hemostatic system, they don't live very long. They'll bleed out very, very quickly. And so our hemostatic system is essential to living past the next few minutes because this system is always working. Obviously, if a large vessel is cut, having a blood clot will save our lives. And so, of course, we want our blood clotting system to function properly. However, sometimes it doesn't quite function properly, and we can create blood clots that obstruct blood flow in critical vessels. And when blood clots obstruct flow, we call those embolism. And so heart valve structures, they construct not only blood flow in critical vessels, you can obstruct heart valves and other structures that are essential to normal hemodynamic function. We could just take but a thrombus can obstruct blood flow in critical vessels. You could just turn the rest of this black, and we get the point right here, all right? Our grammar lesson of the day: a thrombus is a singular blood clot. Thrombi are multiple blood clots, and thrombosis, anything that's osis, is the pathologic presence of something. And so a thrombosis is the presence of a blood clot. All right, so again, a thrombus is a blood clot. Please do not confuse that with embolus. An embolus can be anything that blocks a blood vessel. And so when a thrombus forms in one place and then blocks a blood vessel downstream or somewhere else, it will be called an embolism as well. However, we can break large bones and cause fat embolism. We see that in trauma. A woman delivering a baby can have a rupture of her uterus and her placenta and lead to amniotic fluid embolism. And then certain devices that we put in, medical devices that we use, ports to access blood supply in a patient, those can be left open and result in air embolism as well. And so an embolism is anything that blocks a blood vessel. However, a thrombus is a blood clot, and a thrombus can be an embolus as well. Embolus singular, emboli multiple, embolism, the pathologic presence of an embolus. All right, that's our grammar lesson. All the medications that we're going to talk about are used to treat these things: acute myocardial infarction, ischemic stroke, acute ischemic stroke, deep vein thrombosis, which leads to pulmonary embolism. Usually getting clots in our legs results in those breaking loose and going to the lungs. They don't necessarily have to be in our legs. We have people who've had deep vein thrombosis in their arms, and what we try to do is avoid those deep vein thrombosis, thrombi, from breaking loose and causing pulmonary embolism. Acute peripheral arterial occlusions, we don't see that so much. And then something to keep in mind is occlusion of indwelling catheters. If somebody has a catheter that they carry around with them, it's like a long-term IV, long-term large bore IV. Sure, we can open up that catheter using the thrombolytic drugs. However, we got to be very careful about how we use them in myocardial infarction, stroke, and pulmonary embolism, as well as DVT. Now, keep in mind when we treat an acute myocardial infarction, that's usually an emergency situation, and so we'll talk a little bit about that, as well as acute ischemic stroke. All right, you need to divide all the stuff that we're talking about into two categories: drugs that prevent blood clot formation, and then drugs that actually dissolve the blood clot. And occasionally we'll use those drugs to open up an indwelling catheter. That's not an emergency situation. However, when we use the drug systemically in a person, that's usually an emergency situation. That's always an emergency situation, because the drugs that dissolve blood clots, they come at a risk. All right? Obviously, the risk is bleeding. And so what we'll see is that we'll use drugs that prevent thrombus formation and then rely on the body to naturally remove the blood clot. And so make sure that you know these two things in your head, that when we're using anticoagulants, when we're using platelet aggregation inhibitors, we're preventing the formation of new blood clot, but we're not dissolving the blood clot. Your body can do that naturally in most circumstances. All right, well, if you read a real book about blood clotting, there's all sorts of interesting components, ingredients in the blood clot. However, when we talk about pharmacology, the main two blood clot components are platelets and fibrin. And so we'll talk about anti-platelet agents, and then we'll talk about fibrinolytics, things that break down fibrin. And there will be other things that we talk about, but these are the two main components of a blood clot: fibrin, platelets, in case you missed it the first time. There we go. All right, so platelet aggregation, otherwise known as clumping, is an essential part of thrombus formation. So that brings us to our first set of drugs to prevent thrombus formation, the platelet aggregation inhibitors. Aspirin, clopidogrel, which is Plavix, and tirofiban, which is Aggrastat. And there are others as well. They might be on the clinical discussion section. So aspirin, we hear about this on the media all the time. Bayer aspirin used to prevent heart attacks. There's been some new studies that they're scratching their heads about, but we use aspirin to prevent platelet aggregation. And when we talk about the eicosanoids, the prostaglandins, hopefully we'll throw in some thromboxane discussion. But aspirin prevents the synthesis of eicosanoids like thromboxanes. And then the thromboxanes activate platelet aggregation, so aspirin prevents the platelets from clumping, so that the decreasing blood clot formation. Aspirin will enter the body and will exit the body within an hour, but will cause a permanent change to the platelet, which lasts about 7 to 10 days. Right? So when we talked about making covalent changes to the receptor, that's what aspirin does. It makes a covalent change to the thromboxane making part of the platelet. And that lasts until the platelet is consumed and recycled. Clopidogrel Plavix is a platelet aggregation inhibitor as well. You can read the fine print. Something that we talk about when we talk about platelet aggregation is glycoprotein GP2B3A. That's quite a mouthful. And so we'll use different strategies to either prevent activation of that or inhibit it. But I just need you to know that clopidogrel Plavix is a platelet aggregation inhibitor. And commonly we use clopidogrel Plavix after a stent, and so since I have a little extra time today, one of the slides that we're missing is a stent. And so I wanted my slides as well to show you what a stent is. I think the YouTube channel has a pretty good description, and so we'll surf the net a little bit if you guys don't mind too much. If I can even operate an Apple, which is suspect at this point. And you can do what I do. This is what I do. Look, stent, and spell it correctly, S-T-E-N-T, stent. And we'll ask Google what it has to say. Oh, there it is. And it's a small, oh, what a beautiful picture. We'll start with that right there. Yeah, sure we will. See if we can make that any bigger. Oh, of course. Well, here. We'll just copy the image and stick it on my slide, see if that works. Very good. And then some right-click, paste. All right, so what we see with a stent is that here's a narrowed artery with atherosclerosis, and we take them to a catheter lab, the cath lab, as we call it. And we have a fluoroscope, with just one F, and we can take a balloon, put it in the artery of, usually their arm. It doesn't have to be their arm, it can go in their leg. And we'll take this little catheter with a balloon on the end of it that has this little wire mesh on it. And then the wire mesh can be expanded with a balloon. So there's the deflated balloon, and here's the wire mesh, and we take this balloon and we inflate it, and now we have this, we can take the catheter out and the balloon out, and now we have this wire mesh holding the artery open. This is a very common procedure. One of the main problems, with this procedure is this wire mesh does what? It disrupts the endothelium, and this is a notorious cause of blood clots, especially people who do not take their medication. And so I've met all sorts of people who get stent placements and they decide, oh, well, I'm going to quit taking my Plavix because I feel okay. And you must take your Plavix after a stent is placed. And so it's very important when we educate our patients that these stents can make the situation real bad, real fast, if they do not take their Plavix on a regular basis. And so after somebody gets a stent placement, we want them on Plavix. The usual is 6 months, some people more, some people less, but the usual is 6 months, and they have to be very compliant with that. And so we use platelet aggregation inhibitors after stent placement. Some people use this in combination with aspirin as well. It's fun to hear people argue about whether that is a good thing or a bad thing, but don't be surprised if somebody's on both aspirin and Plavix to prevent blood clot formation after a stent. After the stent is placed, the endothelial lining will grow around it and form nice smooth edges, and we don't worry about blood clot formation after that. That's about 6 months later. They can stop taking the Plavix. Depending on who your doctor is and what they tell you, please follow your doctor's instructions. Tirofiban aggrostat is a newer platelet aggregation inhibitor. We'll use that in certain situations, cardiac situations, where cardiologists are involved. And again, it's going to block the GP2B3A receptor, and that's involved in platelet aggregation. All right, so what I want you to know, there's more glycoprotein 2B3A inhibitors for those of you keeping track. Aggrostat, Riapro, Integrelin, these are all platelet aggregation inhibitors. All right, but I definitely want you to know these 3 drugs right here as platelet aggregation inhibitors. All right, another form of anticoagulation is heparin. Where I thought that would say anticoagulant somewhere. All right, so we've covered the platelet aggregation inhibitors. Let's talk about some anticoagulants, heparin being one of them. We'll talk about 2 types of heparin, enoxaparin, which is down below, and then heparin, which is above. Enoxaparin is also known as Lovenox. It's a low molecular weight heparin. All right, so heparin are these like these chains of glucose, and there's all sorts of different types of heparins. When you use heparin in an IV, there's a collection of different types of heparins in the drug. And then enoxaparin, we've taken the heparin and fractionated it. So we take the smaller ones, the lower molecular weight ones, and we call that enoxaparin Lovenox. And so these are the 2 main heparins that you'll see in use in the clinical setting. All right, so let's talk about how they work a little bit. Here is the endothelial cells lining the inside of a blood vessel. And damage to the endothelial lining can initiate the coagulation cascade. And we saw this, and now I'm worried about my slides. We saw this with the atherosclerosis that formed a plaque, and this is exactly what happened. So here's my endothelial lining, and it will ulcerate when it's sitting on top of a plaque and expose something called tissue factor. All right. And this tissue factor will initiate the coagulation cascade. All right. Coagulation is turning a liquid into gel. When you make Jell-O, you're taking a liquid and adding these substances to the water to form a gel, hence Jell-O. All right. Cascade is a waterfall. Cascade is where the water comes and it hits a stone and then splits in 2 different directions and then hits another stone and splits in another direction. And so a single stream feeding the cascade will result in hundreds of little teeny tiny waterfalls downstream. And that's why we call it a coagulation cascade. All right, the coagulation cascade is named by Roman numerals. And the Roman numerals basically are in the order of which they were discovered. It's not the order which they set off the cascade. And so rather than using Roman numerals, we'll just use alphabet letters to show the cascade. And so what I'm trying to show you here is the first protein in the cascade will set off all sorts of next proteins in the cascade, which set off all sorts of next proteins in the cascade, which set off all sorts of next proteins in the cascade. And then the signal is essentially amplified. And so by activating one protein A, I can eventually activate countless protein Fs downstream. All right. So again, the single activation of one factor that signal can be amplified rapidly and result in activation of all sorts of downstream factors. All right? And so that's what we see with the coagulation cascade. And again, they're named in Roman numerals, and they occur in an order that doesn't make sense, and I don't really need you guys to know that. I just need you to understand this concept. One of the main reason that we have a coagulation cascade is so that we can quickly amplify the signal. But not only do we quickly amplify the signal, but we can actually quickly stop the signal as well, because we have all sorts of little control points along the way. And so by blocking any of the steps along the activation, we can stop downstream activation. So cascades not only allow for rapid activation, they also allow for careful control and rapid deactivation. All right, so again, we're talking about atherosclerosis and the ulceration of that endothelial lining, exposing tissue factor, and then this tissue factor initiating the coagulation cascade, which then causes a blood clot and a thrombus, and that's what we're trying to avoid. For those of you keeping track of the Roman numerals, tissue factor, where this is all starting, is called factor 3. It's also called tissue thromboplastin. And when I was making these slides several years ago, the people I was getting my information from, they're like, we got to get rid of all the Roman numerals because nobody knows what that means, and they don't occur in an order that makes any sense. All right. Tissue factor. Tissue factor will activate something called factor 7. Factor 7, the coagulation factors are made by the liver. And so it takes several days to manufacture there, but they're proteins that are made by the liver. Somebody in liver failure will have very poor blood clotting factors as well, and so poor blood clotting abilities is one of the bad signs in liver failure. So this factor 7, it's made by the liver. It's floating around in the blood, and when it comes in contact with tissue factor, it will stick to it and activate factor 7. It will activate the factor, and now it's called factor 7A. And it doesn't necessarily have to stick to it. It can float around the blood as well. All right. And so when a factor is activated, we'll give it the letter A. And so that's the only difference between factor 7 and factor 7A, is that when the blood clotting factor is activated, then it's ready to participate in the cascade and activate something else in the cascade. In this case, we have factor 10. Pay attention to factor 10 because we're going to have factor 10A inhibitors. There are factor 10A tests out there. And so when factor 10 comes along and sticks to factor 7, then we call it factor 10A. And we'll talk about factor 10A inhibitors. All right. Factor 10A will bind to factor 5 and activate factor 5, and the combination of those will be called the as in thrombinase, thrombin blood clot ACE as in protein complex. Right? And it's the prothrombinase complex that will convert prothrombin, which is known as factor 2, into thrombin, factor 2A. Right? And again, when you take other classes, they try to get you to memorize all the Roman numerals. I generally don't recommend that. Being able to know that factor 10 and factor 10A are part of the blood clotting cascade is an important part of pharmacology. All right, we'll make this a little bit smaller here so we can continue the story. Thrombin will make fibrinogens. Fibrinogens, again, are these little fibrous proteins floating around in the body, and thrombin will then put them together. So fibrinogen, which is factor 1, will get polymerized. Polymerize means to stick molecules together, poly-mini-mer molecules. And when we stick the little molecules together, it turns into fibrin. And remember, fibrin was a major part of our blood clot. And so these are the steps we'll talk about as we talk about how to prevent fibrin from forming. All right, so it took this coagulation cascade to initiate the formation of fibrin, the main part of our blood clot. And then the fibrin will cause platelet aggregation as well, because the platelets will stick to the fibrin. And so there's basically two paths that we can go through. We can get platelets to stick together and then form fibrin, and then we can form fibrin and get platelets to stick together. And remember, fibrin and platelets are our main part of the blood clot. All right, so back to heparins, specifically heparin, and then enoxaparin, Lovenox. Right, heparin binds to a naturally occurring blood clotting factor called antithrombin. Remember, there's a cascade that turns the system on, and then there's also a system to turn the system. There's also coagulation factors, antithrombin factors, that are designed to turn the system off. And one of the systems that turns the coagulation cascade off is antithrombin 3. And anti against thrombin, blood clotting formation. Heparin will increase the activity of antithrombin 3. Sometimes you'll hear an antithrombin 3 activator, but antithrombin 3 prevents blood clot formation, and then heparin increases its abilities by tenfold. So antithrombin 3 prevents the activation of the coagulation cascade, coagulation proteins, especially by interfering with thrombin in factor 10A. And so again, antithrombin 3 interferes with thrombin and factor 10A, and in the presence of heparin, it increases its abilities by tenfold. And so you might hear heparin referred to as an antithrombin 3 activator or antithrombin 3 facilitator. All right, when somebody is on heparin, the effect is immediate. Something to know about heparin, it's an IV drug. All right. When we talked about the platelet aggregation inhibitors, aspirin and Plavix, those are oral medications. Now we're at heparin, and heparin is an IV medication. We can use it subcutaneously to prevent deep vein thrombosis in the hospital. We use Lovenox for that mostly now. And so heparin works its availability is IV. And so when we talk about the IV anticoagulant, we're talking about heparin. When somebody's on heparin, they have to get a lab test every 6 hours. When somebody's on IV heparin, they have to get a lab test every 6 hours. That's called a partial thromboplastin time. And so in the math modules somewhere, we're going to come up with a loading dose for heparin, and that's going to be based on their weight. And you might see two different loading schemes, a more aggressive loading scheme or a more conservative loading scheme. And then after we've loaded the heparin and let it swirl around, we'll come after 6 hours and test their PTT. And then that'll decide us, we'll start them on a heparin loading dose, and then we'll put them on a continuous heparin drip. And then after they've had the drip for 6 hours, we'll come back and get a PTT. And then from the results of that PTT, we can adjust the heparin drip, either slow it down or make it go faster based on the PTT. There are some people out there that have sliding scale heparin drips. If their PTT is this, run the drip rate here. If the PTT is there, run the drip rate at this rate. I never like to do that. I just like to know what the PTT is and then adjust the drip after that. But again, it's an IV medication, and the important thing to remember is that its effect is immediate. And so as soon as you put somebody on heparin, its blood clotting abilities, its abilities to anticoagulate begin immediately. But again, remember, heparin does not dissolve blood clots. It prevents new blood clot formation. We rely on the body to naturally break down the blood clot when we're using heparin. There is the opposite of heparin. When we put somebody on heparin, we expect to anticoagulate them. We expect to thin their blood. We expect to decrease blood clot formation. But very rarely something exactly opposite will happen. We'll put somebody on heparin, and it will make them hypercoagulable. And I used to have a really nice slide on this, but I think it ran away one day. It's very rare. But it's this immune heparin-induced thrombocytopenia is what HIT stands for, if I recall correctly. And that's when your immune system has this response to the heparin and causes hypercoagulation. Most of those people who survive the event know who they are, and they know that they're supposed to tell you that they can never take heparin. But be aware of that. It's very rare. It's much more common on board questions than it is in reality. And so be aware that there are people who have a certain type of immune condition that makes heparin very dangerous for them. It doesn't work as a blood thinner. It works exactly the opposite of them. And on my slide, it's called HIT. I know it has other names as well. All right, if somebody is overdosed on heparin, and it's not too uncommon for this to happen with you, because everyone is so much different. You'll take two identical people, they will look the same, they'll weigh the same, they'll have the same background, they'll be on the same medications, you'll load them up heparin in exactly the same way and run them at exactly the same drip rate, and one person will be underdosed and the other person will be overdosed. And so dosing heparin properly for individuals is an individual thing, and that's why we run the test every 6 hours and make sure that they're doing okay. We run the PTT every 6 hours when somebody's on IV heparin. In certain circumstances, if they've been way over heparinized, then we can use protamine to reverse the heparin. What it does is it binds to the heparin and prevents it from working. And if you remember early on, we used to call that a chemical antagonist, where the chemical antagonist would actually bind to the drug and prevent the drug from working. And so that's what protamine does. In my clinical practice, I did not like to use protamine. I did not like to use protamine ever. There was one time when I was in residency, and something happened with the IV pump. Either it wasn't hooked up correctly or the pump wasn't working. I stuck a not functioning tag and sent it to biomedical engineering. But somebody had been way overdosed on heparin. And rather than give them protamine, we just watched them very carefully for any signs of heparin overdose. And they did fine. Because heparin is a natural occurring substance in the body designed to prevent excessive blood clot formation, I think we have to be very careful about using protamine. I've seen more problems with people causing hypercoagulability trying to use protamine to reverse the heparin than letting heparin wear off on its own. So when I read things about protamine, they're like, oh yeah, give them protamine and it'll reverse it. And I always just try to avoid protamine whenever it happens. I mean, they're already overdosed with one drug. The last thing you want to do is overdose them in the opposite direction. All right, so. But protamine is the reversing agent for heparin. And I'm sure somebody out there disagrees with me about when to use protamine. All right, well, there is a special form of heparin called enoxaparin. There are other low molecular weight heparins. They'll also be called fractionated heparins. Fractionated meaning that you separate them out in some kind of method. And so enoxaparin is also known as Lovenox. It has much more specific activity against thrombin and factor X than heparin does. But the nice thing about Lovenox is that it does not require lab monitoring. Somebody out there thinks that they're supposed to get PTTs every 6 hours, but that's not true if you read carefully. Somebody on subcutaneous low molecular weight heparin, enoxaparin, Lovenox, they don't have to get lab tests. But this is one of the most commonly used drugs in the hospital because this is something that we'll use to prevent pulmonary embolism. And so one of the problems that we've had in hospitals, we still do, but it was much worse in the past, is when somebody is laying in a hospital bed not moving around and they have all this increased risk of blood clot formation. Them laying in the bed and not moving increases their risk of developing blood clots in their legs. And because those blood clots are in the veins of their legs, those will go into the vena cava, and that will go into the right atrium and get pumped to the lungs, causing pulmonary embolism. A little caveat right now, the lungs are kind of like a filter for veins that throw blood clots, because the lungs prevent the blood clots from going to the brain. Because they'd have to go into the left ventricle to be pumped up into the brain. And so DVTs do not cause strokes unless they have what? A ventricular septal defect. If they have a hole in their heart where the right side can pump into the left side, people with ventricular septal defects or atrial septal defects where they have some kind of right to left hole, they can pump blood clots into their brain. And so those people will have strokes from deep vein thrombosis. And so everything you read, there's like, oh, it doesn't go to the brain because the lungs are filters for blood clots. But the truth is, if they have a hole across their septum, then not only do deep vein thrombosis cause pulmonary embolism, but they can cause stroke as well. And so this is why when somebody's in the hospital, if they're going to be there more than a few days, we're super aggressive about making sure we prevent pulmonary embolism. And one of the ways we do that is one of these things right here, sequential compression devices. And so here's the little air pump. And then you put them on your legs, when you put them on their legs, and when you're going to the hospital, you'll see this all the time. And it'll start to squeeze down here, and then squeeze there, and it'll squeeze in an uphill manner, pushing the blood out of their legs. And there's like a massager, and by massaging the legs, we can keep the veins moving and moving blood towards the body. Obviously, we do not want to use these if we think they already have a deep vein thrombosis, and so that's something you'll want to be aware of. If we see that they have a deep vein thrombosis, we certainly don't want to put these on them to break the deep vein thrombosis loose. And one of the ways we'll look for deep vein thrombosis in their legs is with an ultrasound. And the most common sign of deep vein thrombosis is one leg's bigger than the other and it hurts. They'll hurt in the calf. And so when you see somebody with one leg bigger than the other, the first thing I think is deep vein thrombosis, unless they have some specific medical history that would suggest otherwise. So a lot of people, they have edema, like with congestive heart failure, you see that all the time. But when people have congestive heart failure, it's usually equal in their legs on both sides. You're not going to see one leg bigger than the other, unless they have some kind of pelvic floor problem that's interfering with blood drainage. So the main reason that we see when we see deep vein thrombosis is one leg's bigger than the other. And it's painful. So we'll get ultrasounds for those. And not only can we prevent those using heparin and Lovenox, but we'll treat those as well. And again, we don't want the problem's not so much the blood clots in the legs. The problem is the blood clots breaking loose and going to the lungs in the hospital, or going to the lungs, period. In the old days, 50, 60 years ago, deep vein thrombosis leading to pulmonary embolism was the leading cause of death in a hospital. So we're very aggressive about this. All right, let's talk about the factor Xa inhibitors. We went through the blood clotting cascade a little bit and talked about how factor Xa worked. These are commonly used to treat atrial fibrillation. All right, obviously factor Xa inhibitors interfere with factor Xa. And the cool thing about the factor Xa inhibitors, they talk about Xarelto. Anytime you watch TV, they talk about Xarelto, and then maybe Eliquis. The other two I don't see too much about. Erixtra is an older factor Xa inhibitor. But something that's cool about the factor Xa inhibitors is there's an XA. But by the way, this isn't. This is pronounced factor Xa. Not factor XA. So when people say, "Oh, that's a factor XA inhibitor," I'm like, "You never watched the lecture." All right, so that's how we know. But there's a little XA in the names, and so somebody, and I want you to see the ban as well, like interfering with factor Xa. And so somebody, they were on something I'd never heard of, Exaban, and I'm like, "Oh, that's a factor Xa inhibitor." They're like, "Oh, you're right." And so the factor Xa inhibitors, they have that XABAN in them. And that's where that comes from. And they're commonly used in atrial fibrillation to prevent stroke. Another drug that's older than the factor Xa inhibitors. Before the factor Xa inhibitors, we used Warfarin, which is also called Coumadin. And this interferes with blood clotting as well. And so when somebody had atrial fibrillation, then they had a very high risk of stroke. If you have somebody in the emergency room comes in with a stroke, one of the first things we're going to do, besides stabilize them, of course, is to get an EKG looking for atrial fibrillation. And we talk about that in 2.6. And so something that warfarin does, by the way, this is an oral medication, and it interferes with the liver synthesis of blood clotting factors. They'll call them the vitamin K dependent blood clotting factors because you need vitamin K to make these. All right, so if you're deficient in vitamin K, it's going to interfere with your ability to clot your blood. All right? And most of us that have a modern diet, we don't have vitamin K problems. And I listed a few here because they were the ones we talked about on our slides, but your liver makes the real blood clotting factors. And it takes them a long time. It takes the liver a long time, like 3 to 7 days, to make any of these factors. All right. So something we'll throw in now, because these are vitamin K dependent factors. Vitamin K is the reversing agent to reverse the effects of warfarin. It takes several days for that to work. So you give somebody vitamin K today, it's going to take several days for that to reverse the effects of Coumadin. You'll see that a lot if somebody is on Coumadin and they're coming in for surgery. We'll want to not only stop the Coumadin, but we'll want to reverse the Coumadin as well, and we'll do that with vitamin K. Phytonadione, that's its generic name. Aquamaphytin, we still use that word, even though the trade name has officially been untraded. The manufacturer doesn't call it aquamaphytin anymore. But if you're in a clinical setting, that's what we'll call it, aquamaphytin, and it is just an aqueous solution of vitamin K that we will use to reverse the effects of Coumadin. Hopefully you remembered from lecture 1.5, remember how we caused a seizure by stopping a blood thinner? Right? So again, Coumadin is very protein bound, and when we stop the Coumadin, then we can decrease serum blood levels of other drugs that are highly protein bound. So again, keep this in mind when we're stopping Coumadin, especially the surgical people. They want to operate on somebody, they don't want them to bleed, and so they just want them to stop blood thinners, and they need to remember that that's going to affect drug levels of things like Dilantin if they're on both drugs, and other drugs that are protein bound. All right. So don't be in a big hurry to reverse this stuff so quickly without thinking about what's going on. All right, so somebody has atrial fibrillation and we put them on warfarin, Coumadin. And remember, this interferes with vitamin K, the formation of vitamin K factors, blood clotting factors. And so then they're like, oh, well, don't eat any vegetables because that might make your vitamin K levels go up. I don't really like these instructions. What you don't want to do is eat some giant spinach salad one day and then not eat any greens the next. As long as your vitamin K intake, and that includes green leafy vegetables, as long as it's consistent on a day-to-day basis, then there's not a problem with this, as long as you follow along with your PT-INR on a regular basis. And so PT-INR is the lab test that we will use for warfarin, Coumadin. Now let's reverse and go back to heparin. Remember, that test was PTT, partial thromboplastin time, because heparin's IV. We dose it. We check the PTT every 6 hours while they're on an IV drip, right? And then that effect is immediate. And so if we give them heparin right now, it's going to affect their PTT as soon as we take it. That is not the case with PT-INR, and I've bumped into all sorts of clinicians who don't realize this. Remember, Coumadin, warfarin, is interfering with what? The formation of proteins. And so the warfarin that we take today is going to affect PT-INR 3 and 7 days later. Right? So if you give somebody a Coumadin today, it's not going to affect their PT-INR if you turn around and measure it right then, because it's not like heparin. Right? It's different. In the old days, we had this thing called a prothrombin time, and that came from the lab back when I was a lab tech and a phlebotomist. We just had prothrombin times. And what a normal prothrombin time varied depending on the lab controls that we were sent. And so we'd have to write that. And then it was confusing for the doctors. And this is like, what's a normal prothrombin time? Well, it depends on the standards that they used when they calibrated the machines. And then eventually they came up with an international normalized ratio, and that's what that stands for. And so now we just call it a PT-INR. And really the test we use is the INR. The INR is consistent among patients, and so like if somebody has atrial fibrillation and they're on Coumadin, we'll want their INR to be 2. And then if they've had a failure, maybe we want it to be 2.5. If they have a mechanical valve in them, maybe we want their INR to be 3. Right? So INR very simplified the prothrombin time situation that we used to have before they invented the INR. Again, because the warfarin affects the manufacturing of proteins in the liver, it takes 3 to 7 days for it to take effect. And so something to keep in mind, because this is an oral medication, something that used to be very common, and still is from what I hear, is that somebody comes in with a deep vein thrombosis, maybe we'll put them on a heparin drip immediately. And then once we're satisfied with what's going on, we can start them on Coumadin. And are both medications working at the same time? No. The Coumadin is going to be working 3, 4, 5 days down the road because it affects blood clotting, the formation of blood clots, but the heparin works right now. And so somebody comes in with a blood clot, we would put them on both medications at the same time. And we'd measure the PTT for the heparin every 6 hours. And then we'd start them on warfarin. Usually the warfarin Coumadin, we would have to load that. Now, again, with the Coumadin, everybody would be completely different. You can take 2 people, they can look identical, they can have identical backgrounds, identical weights, identical everything, and you start them on one dose. You start them both on exactly the same doses, and one person is overdosed and the other person is underdosed. And so it's very individual dosing. But warfarin also requires a loading dose to get it up and running. And so a typical dose to get a normal person dosed on Coumadin, maybe 10 milligrams the first day, 5 milligrams the day after that, and then 2.5 milligrams a day. And we'd start running PT-INRs from day one just to show you that, yeah, we give them 10 milligrams of Coumadin, it's not going to affect the PT-INR. For some people, that's way too much. For other people, that's not enough. All right, so again, you have to decide, the clinician decides that. But once the INR starts to be where you want it to be, like 2, with their Coumadin, then you can stop the heparin, all right, because you only need one of the drugs to be functioning. But that's why we'd start them both at the same time. So the heparin's working right now, the warfarin's going to start working 3-4 days from now. So again, the dose they get today is going to affect blood clotting several days later, and I've had all sorts of arguments with people about this who were wrong if you go read the books. Right? Yeah, that's a new picture. Yeah, the rumors are true. Warfarin was originally developed by the Wisconsin Alumni Research Fund to develop a rat poison. Because they thought, oh, they'll give it this rat and then it'll cause them to bleed to death, like in the walls of the house or where you don't want. So Coumadin, and by the way, it doesn't work very well either, especially here in Hawaii. The rats are generally resistant to Coumadin. And so one day they realized it's not a very good rat poison, but this is excellent at preventing blood clots, especially in atrial fibrillation. And warfarin, you know, for all its rumors about rat poison, has saved countless lives in the prevention of stroke. I will tell you about internal bleeding. Everything that we're talking about today can cause internal bleeding, and we have to be on the lookout for that, especially in elderly people, notorious for getting gastrointestinal bleeds. All right, so whether they're on aspirin or Plavix or any of the platelet aggregation inhibitors, whether they're on heparin or Lovenox, whether they're on the factor Xa inhibitors, whether they're on Coumadin, warfarin, we have to be on the lookout for gastrointestinal bleeds. And so it's good to get a CBC and then the tests to test for blood in their stool. All right. And clinically, you want to be aware that even if you dose them perfectly, there is the potential for bleeding. And so it says, oh, as long as they're carefully monitored, there's no ill effects. Well, other than gastrointestinal bleed or some other kind of bleeding. All right. Stuff we're talking about is absolutely contraindicated in pregnancy while the baby's developing. So warfarin Coumadin is a Category X drug. The FDA doesn't like us to use categories anymore. They have more complicated situations. But when you communicate with other people and read stuff, they use the FDA categories, the pregnancy categories all the time. And again, Category X is absolutely contraindicated in pregnancy, or women who are trying to become pregnant or may become pregnant. Again, warfarin is the oral medication. There is an IV form, but there is no difference in its ability to work. And so when they talk about the oral anticoagulant, they're usually talking about warfarin, Coumadin. And so the most common use for warfarin, Coumadin is to prevent blood clots in atrial fibrillation, the leading cause of stroke. But the factor Xa inhibitors are used more and more as an alternative. When they came out with Lovenox, I was like, oh, this is going to replace heparin. We're never going to use heparin again. Well, we use heparin all the time. When the factor Xa inhibitors came out, they're like, oh, we're never going to use Coumadin again. And that's not true either. Right? But the factor Xa inhibitors are an alternative to warfarin, Coumadin, and they don't require blood monitoring. All right, so if you remember from 2.6, since we did this out of order the last time I did this, there's my sinus rhythm, and on my sinus rhythm you can see little P waves. Little P waves are like the fuses that cause the big QRS complex. The big electrical blips are QRS complexes. And you can see 1, 2, 3, 4, 5, 6, 7. So this heart rate's 70, 7 QRS complexes in a 6-second strip. And what I wanted to show you is the P waves before each QRS complex, because they're causing, these P waves are causing each QRS complex. All right, well, the atrial fibrillation, the atria are fibrillating, they're vibrating, they're sitting there shaking. And so notice we have no P waves. Notice our heart rate here is 80 because there's 8 QRS complexes in the 6-second strip. Most times in atrial fibrillation, they'll have a very rapid ventricular response, and we'll have to slow them down. But here with atrial fibrillation, the blood will clot against the atrial walls. And then that blood clot will break loose, and in the left ventricle, that will break off and go up to the brain. All right. And so atrial fibrillation is the leading cause of stroke. It causes a lot of harm in a lot of people. Again, something I wanted to bring up about atrial fibrillation is because the atria are notorious for forming these clots and then breaking loose and going to the brain. We don't want to convert atrial fibrillation to a regular rhythm until we know that there's not blood clots on the atrial walls. And so we'll do something called a transesophageal echocardiogram, or take something like the EGD that you go and look at the stomach. We can put an ultrasound probe on the end of that and do an ultrasound of the heart from the esophagus, because we don't have to, the ribs don't block our view. And we can see right into the left atrium and see if there's blood clot formation. If the person's unstable with atrial fibrillation, then of course we want to convert that rhythm. But if they're stable, we want to wait and anticoagulate these people with either warfarin or Coumadin. Warfarin or factor Xa inhibitors. All right? And we want that to work before we actively try to convert that rhythm. All right. All right, so we talked about drugs to prevent thrombus formation. We talked about the platelet aggregation inhibitors. We talked about heparin and the other heparin, enoxaparin, Lovenox, low molecular weight heparin. We talked about factor Xa inhibitors, and we talked about warfarin and Coumadin. Again, I want you guys to remember that those do not break down blood clots. They prevent new blood clot from forming. All right, and then we rely on the body to naturally break the blood clot down. All right. So now we're going to talk about drugs that dissolve thrombus. And sometimes we're going to use them to open up an indwelling catheter like an IV. That's not an emergency situation, but when we use these drugs we use in emergency situations. And most of the time that is either stroke, myocardial infarction, or pulmonary embolism. All right. All right, so these are the thrombolytics that I want you to know about. Alteplase, which is TPA, this is the naturally occurring enzyme in the body that breaks down blood clots. And then there's Retaplase, which is a little bit different than TPA. They'll call it Retavase. You'll also see it called RTPA for engineered TPA. And so Retaplase, you'll see it called RTPA. And then tenecteplase, I see it everywhere, I've never seen it used, is TNKase. And then the older ones, the older thrombolytics are streptokinase and urokinase. All right, thrombolytics. We call them thrombolytics because they break down blood clot. But remember when I told you about medical nomenclature, you know there's like a million words for the same thing. And somebody didn't like the word thrombolytic because it doesn't really break down the whole thrombus. What these do is actually break down the fibrin. All right? So they don't like to call them thrombolytics. They like to call them fibrinolytics. And this is very confusing for people because there is no difference between the fibrinolytics and the thrombolytics. That means the same thing. All right, well, to make things even more complicated, we're going to divide the fibrinolytics into two categories. All right. There will be ones that are fibrin specific, and that's TPA and retivase, and T and Ks. I definitely want you to know about TPA and RTPA. Right. The older ones are nonspecific. Oh, I'm sorry, that slide's missing somewhere. All right, so these are the fibrin-specific ones, and then the ones on the bottom are not specific. Right, you'll hear them called non-fibrin-specific fibrinolytics. All right, so now we have fibrin-specific fibrinolytics, and then we have fibrin non-specific fibrinolytics. Right. So we'll try to sort all that out. All right, so again, remember, fibrin and platelets are our main part of a blood clot, especially when we talk in pharmacology. All right. All right, on the fibrin are these things called plasminogens. All right, now there are plasminogens floating around in the body too, in the blood. All right. But the plasminogens also stick to the fibrin. And so when the fibrin forms, there are plasminogens stuck to them. All right? And that's part of the reversing system. These plasminogens are part of the reversal system. Right? TPA, tissue plasminogen activator. All right, now notice, these are my plasminogens. They're stuck to the fibrins. All right? This is a naturally occurring thing that goes on. And TPA activates them. And when TPA activates them, ogen just means in the beginning, and converts them into plasmin. That makes sense. Before they were plasmins, they were plasminogens, which is the same thing as calling them proplasmins or preplasmins. And then tissue plasminogen activator activates them, turning them to plasmins. And plasmins are what dissolve the fibrins and make them float away. So that's how TPA breaks down blood clots, by activating the plasminogens. And then again, the plasminogens are a part of the fibrin, and we activate them, and they break down the fibrins. And TPA and retivase and tenectin, they all work the same way. T and Ks. So they're called fibrin-specific because they activate plasminogens that are attached to the fibrins. All right, so let's go back. There's my plasminogens stuck to the fibrins. All right, and tissue fibrin-specific fibrinolytics activate these plasminogens, not the ones floating around in the blood, but specifically these, and that's why they'll be called fibrin-specific. So they're called fibrin-specific because they activate the plasminogens that are specifically attached to the fibrins. The fibrin non-specific ones are streptokinase and urokinase because they will activate the plasminogens that are not bound to the fibrin as well. Right? And there are situations where they'll want to use these. Something I'll throw in, I don't know if it's in your notes. No, it's not. Streptokinase comes from, and I know there's a quiz question about this, streptokinase comes from strep bacteria. And so people have a very high rate of allergic reaction to streptokinase. Right? Urokinase, that comes from urine. And so people have less of an allergic reaction to this, but we don't see a lot of urokinase in use. But we do see a lot of streptokinase still get used, especially in indwelling catheters. And then there are situations, maybe they are actively clotting, and we want to not only we want to treat the plasminogens. We want to activate the plasminogens in plasma as well. I was reading something about that. I was going to put it in my slides. I'm like, well, that's ridiculously complicated. We'll leave it out. All right, but anyway, that's where that fibrin-specific, fibrin-non-specific comes from, is whether they're activating the plasminogens that are specifically sticking to the fibrin or whether they're activating fibrinogens floating in the blood. Those are non-fibrin specific. All right. Make sure you know the difference between drugs that just prevent blood clot and drugs that actually break down blood clot. And again, the thrombolytics are also called fibrinolytics. All right. They will be used in the emergency treatment of acute myocardial infarction, acute ischemic stroke, and then you might as well put pulmonary embolism up there as well. That's missing from my slides. There's a few other reasons to use emergency thrombolytics, but these are the main two things you'll see in an emergency room. And then there's criteria. Just because they're having a myocardial infarction doesn't mean you're going to give them thrombolytics. Because the thrombolytics can be very dangerous when used systemically. They can cause bleeding. They can cause a brain bleed, and that's very traumatic. And so we have to be very, very careful. We have to have specific criteria which facilities can even use these to treat stroke and myocardial infarction. All right, good. I wanted to throw some EKG stuff back at you. So again, here's my normal sinus rhythm, and what I wanted to point, I'm going to draw out a little black line there. There's my black line, and that black line is showing you what's called the baseline. All right, notice that the P wave, when the P wave forms, and then before it becomes a QRS, we're back to baseline, and then after the QRS forms, then we're back to baseline before the T wave forms. All right, so you want to see that imaginary baseline in your head. There's my P wave, notice we go back to baseline. There's my QRS, and then we go back to baseline. There's my T wave, and then we're back to baseline, all right? Are we cool with this? Great. All right, well, this is somebody with ST segment elevation. And this is a sign of myocardial infarction. And so the last little bump is the T wave, and the thing leading up to it was the S wave. And notice my S wave doesn't go back to baseline. My S wave goes right into a T wave. We'll call these fireman hats. And so when you see little fireman hats like that on an EKG, you definitely want to notify somebody immediately. So again, one of my little black lines is running against the baseline. And then notice that my S, when I go from an S wave, my QRS complex, before it becomes a T wave, it does not return to the baseline. And this is what elevation is. And here it's like at least 3 millimeters high, if not 4. This person's having a myocardial infarction. All right, if you read carefully, there's things called non-STEMIs. And you don't have to have ST segment elevation to be having a myocardial infarction. All right, but when you see this, when they're having a STEMI, a ST segment elevation myocardial infarction, when we see ST segment elevation, then we think myocardial infarction. All right. And so these will be one of the signs of myocardial infarction. Chest pain. Now again, people don't map the insides of their chests very well, so some people can have jaw pain, some people can have ear pain, some people can have pain in their arm, either arm. All right. People, if they're diabetic, they can't feel the insides of their body very well anyway. Man, they don't have much chest pain at all. All right. So you read a lot of stuff that's saying, oh, you know, the research is done on old white guys, and it doesn't really apply to women or people of color. And that's all true, but it's also nonsense because everybody can have any of those weird symptoms of myocardial infarction. All right, so you want to be on the lookout for that, especially if it gets worse during activity. And so something we like to do is teach EKG technicians around here and then try to teach everybody else this stuff. When I worked in a hospital, we would teach stuff like this to the guy that, you know, delivered the mail. Because if we had an emergency, we needed him to function as a nursing assistant and not be overwhelmed by this, understand where this stuff comes from. So anybody can learn this. All right, with stroke, before we put somebody on a thrombolytic, we want to make sure they're not bleeding inside of their brain. All right. When somebody has a fresh stroke, usually we can't see it at all. And so when somebody is fresh with a stroke, maybe they have a normal CAT scan. By the way, when somebody comes to the emergency room with some kind of brain emergency, the first thing we're going to want to do, besides stabilize them, is do a CT brain without contrast. Why without contrast? Because, so contrast is when we put IV contrast in them to make different things light up inside of the brain. And we don't really need MRIs for this because that takes longer and it's harder to take care of a person inside of an MRI machine. And so somebody having a stroke, they might have a normal looking CT. Right? And so what we do before we put them on thrombolytics, we want to make sure that their brain doesn't have any of this. This is a huge hemorrhage right here. White is blood in the brain. And so without contrast. And so that's why we do without contrast, because if they're bleeding in the brain, the blood makes perfectly good contrast. And so if you send them to the CAT scanner and give them contrast, you're going to make a neurosurgeon or a neurologist very angry in an emergency situation. So that's why we do CT brains without contrast when we're looking for stroke. And if we see that it looks normal and we do not see hemorrhage, this big white glob, then maybe we'll put them on thrombolytics. There are other contraindications as well. This person is a lethal brain bleed, quite simply because it's so huge. And then notice the midline shift. See, here's the midline of the brain, and notice it's a nice straight line. And notice this person, notice this midline is shifted sideways. This part of the brain is squishing into the other side. All right. So yeah, exactly. The point I'm trying to show you is that blood shows up white on a CAT scan. That's why we do it without contrast. Something else to know that we use these drugs are pulmonary embolism. They will have instant they can have instant onset of shortness of breath. Now, people with pulmonary embolism, maybe it's not instant onset, but when somebody goes from breathing normally to short of breath just that fast, then we know that's pulmonary embolism, and we'll be on the lookout for that. There's a blood test we can get that tells us it's a byproduct of clotting. It's called a D-dimer. So maybe you'll see that get done to test for, see if they have a positive D-dimer in pulmonary embolism. If they can survive the trip to the radiology department, maybe we'll get a VQ scan. Or maybe we'll take them straight to the cath lab and put a catheter in them and put dye into their lungs to see if they have pulmonary embolism. The last time I took care of somebody with a PE, we ended up getting a CAT scan of their chest, and they had multiple pulmonary emboli in their chest. All right. So there's all sorts of tests that we can do. But again, if they meet criteria, it can't be a very old clot, because when the clot gets old, it starts to do this thing called cross-linking. And so after the clot's 1 or 2 hours old, it starts to cross-link and starts to become impossible to dissolve with thrombolytics. And so the amount of thrombolytics we'd have to give them to dissolve the clot would be lethal. And so it has to be new. That's why we want to know the time that they had onset. And if they meet the criteria in 1 or 2 hours, depending on what you're dealing with, then we'll give them thrombolytics as long as they don't have any bleeding in their brain or any history thereof. All right. So there are absolute contraindications for fibrinolytic use, and so this is what I want you to know about all medications, is that before you use them, there's really a reason not to use the medications as well. So obviously, if they've had bleeding inside of their brain, we never want to give them a fibrinolytic. Or if we know there's some kind of vascular lesion like arteriovenous malformation. If we know that they have cancer in their brain, then we'll end up with it like this if we give them fibrinolytics. All right. If they've had stroke, even if they've had a non-bleeding stroke in the last 3 months, we're not going to turn around and use fibrinolytics on them. All right. If we think that they have a suspected aortic dissection, if we think their aorta is ruptured, other than the menstrual cycle, if they have any kind of active bleeding, we're not going to give them something that breaks down clots. Bleeding diathesis is just some kind of bleeding, blood clotting disorder. If they've had any kind of head trauma or facial trauma within the last 3 months, depending on where you are, but it's usually 3 months, we will not use fibrinolytics in an emergency situation, or if they've had surgery on their brain or their spine within the last 2 months, because they'll end up looking like this. All right. And even if we use the thrombolytics appropriately on a normal CT, there's still a risk of this happening as well. Intracranial hemorrhage with use of thrombolytics in an emergency situation is not so rare that it's unmentionable. But again, we only use these in specific emergency situations where their risk of death or being severely impaired is very, very high. But again, the use of the thrombolytics does come with risk. If they have severe uncontrolled high blood pressure and they're unresponsive to emergency therapy, there's some numbers floating around out there, but it's very high numbers and they don't respond. Then we're not going to use fibrinolytics. Something to keep in mind with somebody who's having a stroke, their blood pressure will go up. They'll become hypertensive, and that's to optimize their cerebral perfusion pressure. And so when you have somebody in the emergency room with a stroke and their blood pressure's high, well, that's because their brain wants their blood pressure to be high. And that improves their cerebral perfusion pressure. And so you'll see situations where people have come in with a stroke, their blood pressure will be real high, and somebody will be in a big hurry to treat the blood pressure to get it back to normal. And that's fine, other than that impacts cerebral perfusion pressure and can make stroke worse. All right, so there's a fine line. It's not like there's an exact science to deciding who has the hypertension that you want to control. But if they have severe uncontrolled hypertension for some other reason, then we're not going to give them fibrinolytics. And then if they've had systemic streptokinase in the last 6 months, then we're not going to use fibrinolytics again with them. So if you're going to be in an emergency room dealing with cardiac patients, dealing with stroke patients, I met the person in charge of the stroke program the other day at the hospital. I promised her I'd let her come do this for me one day. Maybe if I plan better, we'll have her come talk about all this stuff. All right. But this is stuff I found really fascinating when I went and did the slides, and so that's why I wanted to go over it one more time and spend our entire time together, our hour and 15 minutes, talking about something that I used to talk about in 15 minutes alone. All right, so that's more than enough for one day. I think when we come back, we should be back on schedule and start central nervous system pharmacology. Until then, aloha.